Welcome to those who are just joining us now. Just hang tight for a couple minutes while we wait for people to log on. Welcome to those of you who are just joining us. Please hang tight for a minute or two. We're just waiting to let people log on. Okay, we seem to have stabilized in terms of participants, so I'm going to go ahead and get started. Welcome to the weekly School of Public Health at the University of Washington webinar. As a reminder, this is being recorded, and although anyone's welcome to watch the webinar, keep in mind that this is guidance for people who are primary in the School of Public Health. So if you're primary from another school at UW or from another organization, if I make a comment about here's sort of policies or what you can expect, you should probably check with your own leadership team to see whether or not that refers to you or what the policy is for your own group. A couple of organizational things before we get started. During these webinars, we do not use the raise hand or chat functions, with the exception that when people want to share like a resource, like here's a website with some useful information, feel free to use the chat for that. But if you want to ask a question, please use the Q&A tab. And if you want to direct it at one of the specific panelists that we have, be sure to indicate who your question is for. So our plan for today is I'm going to provide some overarching insights into what's going on right now or this week. And then we're going to transition from that to our special guest for today, who is Ruth Etzioni, who's a full member of the Division of Public Health Sciences at the Fred Hutch Cancer Research Center and an affiliate professor of biostatistics and health services here in the UW School of Public Health. And she's here today to talk to us about the various models that are being used to map and project the pandemic and what we can learn from those different models and how they inform decision-making both locally and at the state level. She'll be joining us in a little bit, as will our other panelists, who today are Janet Baseman, also joining later, who's Associate Dean for Public Health Practice. She'll have some updates that we'll provide at the end after Ruth's presentation. Janet is also a professor of epidemiology in the School of Public Health. We also have Stephanie Farquhar, who's Acting Associate Dean for Education and a clinical professor at both Health Services and DEOHS, and Lisa Manhart, who's our Associate Dean for Research and a professor of epidemiology. So overarching update. So worldwide, as of today, there have been nearly 5 million total confirmed cases of COVID-19 worldwide, with global deaths totally more than 325,000. We are starting to see people in different countries and different regions of the United States go back to work, and different areas starting to reopen. As that has happened, we've seen cases surge in some areas. We're also continuing to see pretty sharp increases in cases in Russia and Brazil and in India, which are current hotspots for the pandemic. Nationally, in the United States, we've had more than 1.5 million cases of COVID-19 documented, with at least 92,000 deaths. As of today, all 50 states have partially reopened, but each to a different extent. As we've talked about many times, public health under our federalist system is the public health and safety, protecting public health and safety is a right reserved to the states. And so it's going to vary from state to state in terms of what the criteria are for reopening, what the plan is. And we're seeing huge differences, as we often do for public health matters, in terms of how different states are handling this. Here in Washington state, we just passed the 1,000 mark for COVID-19 related deaths. And our hearts go out to everyone who has lost someone or who has a loved one who is currently battling with COVID-19. We've had over 18,800 confirmed cases, with almost 300,000 tests having been conducted statewide to date, with an overall positive rate of 6.4%. Super sad news for us in the state of Washington is that John Weisman has announced that he will be leaving the Washington State Department of Health at the end of Governor Inslee's current term in January of 2021. We are so sad. He's been such a great partner for us. It's such a great and inspirational leader within public health for the entire state. But we're happy for him that he is going to another great place. He's going to join the UNC Gilling School of Global Public Health, where he'll lead their doctoral program in public health leadership, very aptly, where he was once a student. So anyway, I'm sure John is not listening, but if you know and appreciate John the way that we do, hopefully send him your good wishes. And thanks for all the amazing things that he's done for this state during the time that he served here. In terms of our local response, we are still in phase 1 here in King County. However, you can go to your dentist now. In fact, my own son has a dental appointment for tomorrow afternoon, which I'm excited about. He probably is not super excited about. And you can also see your doctor for non-emergency procedures, because Governor Inslee last week lifted restrictions for dentists and medical services for non-emergency procedures. That being said, some good news. There's still some constraints in terms of that. Providers need to provide PPE for their frontline workers. They have to have physical distancing measures in place and have that demonstrated. They're supposed to be checking patients for COVID-19 symptoms, so expect to be asked, if not screened, when you show up for a visit. And in addition, providers need to work with their local health agencies to create an assessment of outbreaks in the community so they can be ready to expand or contract services depending upon what's happening with the virus locally. 10 smaller counties in the state of Washington have now been approved for phase 2 reopening. And these are all counties that hadn't had a case for at least 3 weeks. Just as a reminder, phase 2 has many great things in it, including opening of barbershops and hair salons and restaurants at up to half capacity. In addition, this week, actually yesterday, Governor Inslee expanded the criteria for other counties to reopen earlier. So it's the same process where counties become eligible to apply to move to phase 2, but have to have a plan in place. So those counties that have had fewer than 10 new cases per 100,000 residents over a 2-week period can apply to DOH to reopen to move to phase 2. And under this criteria, we currently have another 10 counties in Washington that meet those criteria. Here in King County, where we are not at that low of a case load yet, or number of new cases yet, we do have a new face covering directive that took place effective Monday. And we're expecting other counties to follow suit, already seeing Whatcom and San Juan counties invoking the same measures. The important thing to keep in mind is that these directives are not enforceable, but face coverings are strongly encouraged when people are out in public. So if you haven't already purchased a face covering or created one for yourself, you should do that. Governor Inslee interestingly did back away from a requirement that had been announced that restaurants might have to keep a daily log of their patrons for possible contact tracing as part of phase 2 reopening. That was probably most likely in response to criticism from the ACLU that they felt that was a violation of right to privacy and association. And the governor's office clarified late last week that instead, businesses will be asked but not required to maintain a list of customers who can voluntarily provide that information, and that those records should be maintained for 30 days and then destroyed, and that they cannot be used for sales or marketing or other purposes. You may have seen that a number of casinos have reopened with long lines of patrons eager to gamble again. Tribal casinos are sovereign territories, so they are not subject to the governor's 4-phase reopening plan, but they appear to be following social distancing measures and taking other precautions as would be expected. Governor Inslee also modified some of the golfing restrictions, including allowing foursomes of non-related players, whereas previously you could only have 2 people from, it could only be, it had to be at least 2 people from the same household in order to have and if you wanted 4 people, they all had to be from the same household. I'm saying this wrong, but anyway, it's exciting for the golfers, I'm sure. Okay, updates from the UW campus. UW Medicine announced sad news, which is that they're planning to furlough 1,500 employees. This is due to decreases in revenue associated with not being able to perform elective procedures. The furloughs apply to some professional and classified staff, including management and administrative staff, and can be from 1 to 8 weeks. And again, this is part of an effort to deal with a projected $500 million shortfall. We have also, the whole campus has received from the state's Office of Financial Management a request to model options for a 15% reduction in state funding. So I want to provide clarification that that does not mean that we are getting a 15% budget cut. It's part of the process that we go through, that they ask us to model what that would look like if we had a 15% budget cut, and provide that information to them as they're making decisions about what kind of reductions to make in terms of budget. And it's also important to keep in mind that state appropriations make up about 1/3 of the University of Washington's general operating fund, which supports operations on the 3 UW campuses. So tomorrow, an exciting new online contact tracing training module is going to be launched by the Northwest Center for Public Health Practice. It's called Every Contact Counts, and expect to see a press release coming out about that. That's super exciting news. This week, the Department of Global Health and students from the START Center and the Meta Center for Pandemic Preparedness and Global Health launched a new daily newsletter that summarizes the latest scientific literature related to the COVID-19 pandemic. The newsletter is focused on the needs of public health professionals in Washington State, but could expand to address global needs for up-to-date information. It's a collaboration that they have ongoing with the Washington State Department of Health to help support evidence-based decision-making throughout the region. We'd like to give a shout out to Brandon Guthrie for leading this effort, along with Jennifer Ross, and let you know that you can sign up for the newsletter by visiting the DGH website or the SBH Coronavirus Research and Resources pages on our website. So with that, it is now my pleasure to introduce Ruth Etzioni, who, again, for those of you who missed the beginning of the webinar, Ruth is a full member of the Division of Public Health Sciences at the Fred Hutch Cancer Research Center, and an affiliate professor of biostatistics and health services. Ruth is part of a team of folks who were asked by the state, both the Department of Health and their collaboration with the governor's office, to help them build capacity in terms of modeling. and she's been interviewed a number of different times. I found her explanations to be super helpful, although she'd probably recognize that if I had really learned what she told me, that I might be able to do this webinar myself instead of asking her to come back. But instead, I was smart, and I thought, you know what, I'm going to let you hear it directly from her. She's going to give us a little bit of a tutorial about what are the different types of modeling that are being conducted, and tell us about some of the work that she's been doing with DOH. So with that, Ruth, I'm going to turn it over to you, and I think she's going to share her screen so you guys can see your slides. Thanks, Ruth.
Thank you so much, Hillary, for inviting me. And I'm looking forward to sharing a few words about modeling COVID-19 with all of you. I'm listing here some of our School of Public Health, biostatistics faculty and staff who are also involved in this, but I take full responsibility for this presentation, the views in which are mine and mine alone. I'm going to start with a slide that may be a disclaimer, but may not be. So first of all, as many of you know, I have been a cancer modeler for many years. So I'm not actually an infectious disease modeler. This is something of a plus in that I don't have a model in this space, so I'm completely not conflicted. And because of my history, I'm very familiar with the use of models in the soup to nuts process of policy development. But perhaps my most important qualification is that because I'm a modeler, I get very curious when I read models. So I have no problem poking through the appendix, because that's where the nuts and bolts are. And that's probably why I ended up becoming a voice about models at this time. So everyone is talking about models. You can barely go a day without hearing about COVID models. And there are so many models. Last I counted, there are probably several dozen, and they don't always line up. Some of you may recognize this article from the New York Times, this graphic from the New York Times on April 22nd. This is looking at projections of coronavirus deaths in the US. And this article was all about the variability in the model projections. What's interesting is that the Times revisited the models over the next several weeks and found that they became much more convergent over time. So what's happening, of course, is that the models and the data are evolving. And the models are changing and improving as the modelers learn more about the disease, its natural history, and about modeling itself. I know that I've become a much better modeler the more I have modeled. And so the models are actually changing and being tweaked. And of course, the data is changing and informing the models. And as they become calibrated, and I'll explain what I mean by calibrated in a moment, to the same data, they themselves are converging. Now, I thought I'd include just one slide about how models work. And one of the reasons that model projections differ is that there are different types of models. The slide is meant more to set the stage for later when I talk about how we can use the models for policy than to really teach you about modeling COVID. So there are different types of models. The three main ones are listed here, along with the key parameters that they seek to estimate and use for projections. And the Pacific Northwest is rich in infectious disease modelers across institutions that include the UW, the IHME, the Institute for Disease Modeling, and Fred Hutch. Empirical models are the closest to statistical curve fitting. They posit a smooth shape and use existing data to estimate key summaries, which they then tailor to the evolving US experience. SEIR models are the closest, are the most established type of model for projecting how an epidemic will spread in the population. These models are also called compartmental models because they project movements from susceptible to exposed to infected and recovered, SEIR, compartments based on differential equations that describe the rate of change in the size of each of these compartments. I'm showing you a relatively standard SEIR model, but there are many variations. Now, these models typically rely on many inputs pertaining to disease natural history and outcomes. Most end up being pre-specified based on external studies, and then the models use the evolving data on disease cases or deaths to estimate a few key parameters. One of the key parameters of these models is the reproductive number, R0, or if it's modeled as changing over time, here I've written it as RT, to accommodate possibility that the transmission rate will change over time as different interventions are enacted to mitigate the epidemic. A key thing to note about these SEIR models is that they actually generate a predicted trajectory of the epidemic that is a smooth shape, just like the empirical models. But that shape has a mechanistic underpinning that can then be changed to project what-if scenarios. So while the empirical models' key parameter that they learn from observed data is the summary statistics that describe the shape of the curve that they're assuming, the key parameter that SEIR models learn from the observed data is the reproductive number and how it changes. Now, SEIR models have a uniformity or homogeneity about the way they operate. This can be stretched somewhat, but to really account for the fact that populations are heterogeneous and there are different contact patterns within a population, different clusters, we interact very heterogeneously. To really capture that requires something different. We have two groups doing agent-based modeling, the Institute for Disease Models and our investigators at Fred Hutch, principally Bets Halloran, who's a collaborator with the GLEAM Global Agent-Based Model out of Northeastern University. Agent-based models really try to capture the heterogeneity and how populations connect and interact. They have tons of inputs that specify the structure of a population and that are sourced from many different sources. And these include age groups, commuting patterns, schools, households, and workplaces, and all of the contact patterns that go with them. Given this structure, these models actually, too, like the SEIR models, zero in on trying to learn about disease transmissibility and natural history, also learning about quintessentially the reproductive number from observed data. And they, like the SEIR models, they include many inputs that pertain to disease natural history that are externally sourced. Now, the reason I wanted to just talk for a few minutes about the models is because I want to transition in the rest of this presentation to talking about how we might use the models to address questions of policy. So let's look at something simple like modeling shutdowns. How might each of the models capture and produce projections of the impact of a shutdown like we have effectively experienced under the governor's safer at home order? Now, each model has to express a policy or a situation on the ground in terms of its structure and parameterizations. So with an empirical model, for example, an empirical model might change the mean and variance of the curve that it's fit. The SEIR model would lower the reproductive number. So there would be less transmission or fewer people infected by each infected person. And the agent-based model would alter the contact patterns in its population. So to reflect school closures, the contact pattern in schools would be reduced, and the contact pattern in households would be commensurately increased, thereby providing different opportunity for infected individuals to infect others. Okay, that was a whirlwind, but hopefully we're a little more ready to think about helping policymakers. The one thing I've learned is that it's really important for the modelers to be involved right at the get-go and participate in helping to develop the policy question. And I want to thank Janet Baseman for creating the opportunity for us to participate in this process with the Washington State Department of Health. Our governor is very engaged with modeling, and we've been working with the Department of Health to help develop and present model-based evidence in a way that facilitates sound decisions that are good for public health. And our students have also been involved with the project to bring in-house modeling capability to the Department of Health, because the Department of Health has generally outsourced that capability to groups like the Institute for Disease Modeling, which provide tremendous expertise, but the Department of Health has wanted to have its own model just to troubleshoot and try out simple scenarios. Now, we are working in an environment that's rapidly evolving, so the policy questions keep changing. In February, the questions focused on planning for resource needs. How bad is it going to get? How many hospital beds will we need? How many ventilators will we need? And the goal was mainly a forecasting one. It was all about resources. In March and April, after the Safer at Home order was enacted, the question was more about surveillance and how well this was working to reduce the reproductive number. Then in April, when talk turned to reopening, the question again became a forecasting one, looking at the impact of timing and extent of reopening. And now, as reopening becomes a certainty or becomes a reality, we are concerned with what levels of containment need to be in place to make this sustainable. My teeter-totter there, the idea of balance. Why? So we've gone from forecasting to questions of balance, balancing the impacts of different interventions. And while initially we could rely on SEIR models and even empirical type models to address these simpler questions of forecasting and change in reproductive number, we now find ourselves needing to account for population heterogeneity and much more granular intervention questions. So here's an example of how we worked with the DOH to address a policy question that was a priority a few weeks ago. This question of, this was right at the beginning of May. This was our brief at the beginning of May that we helped the DOH prepare for the governor. Meeting with the DOH, we helped to develop a list of key questions that we provide at the beginning of each of these briefing documents that the DOH distributes when they meet with the governor every week. And we then help them to integrate results from local models and also some national models regarding when to consider reopening. So the DOH have been working closely with the Institute for Disease Modeling, and I'll show you some of the results on the next page. But then the governor actually started asking questions about models that were not local. And we wanted to do some kind of explanation and comparative presentation of the results that pertain specifically to the question of reopening now versus later. So the brief contained this graphic from the Institute for Disease Modeling, and this is posted in one of the reports on their website. And so what it shows is it shows confirmed cases by day, and there are some weekend effects here. That's why we have the drops. And then in the insert is the estimated reproductive number that with the Safer at Home order goes down in April to just below 1. And what they've done is they've looked at reopening beginning May 1st. And the curves, the projected curves show 3 reopening possibilities, and each of which is expressed via an interpretable change in the reproductive number. So the black line shows the projection of the trajectory of cases if the reproductive number R is increases to its mid-March level, just before the safer at home order. And the green is if we retain the safer at home order and R stays and people keep complying to the extent that they're complying. At the time it was estimated in April to be just below 1. And the orange is if we could reduce R even further, but that would involve finding ways to reduce transmission beyond the safer at home order. Note that these projections don't involve specific policies, rather they involve an outcome of policy, the R value. Any specific policy would have to be translated into a corresponding change in transmission. Let you pause and think about that for a minute. A specific policy, we have to know how it would change that R value. And that's challenging. And that's one reason why these types of models are limited when we come to the kinds of decisions we're not confronting. So our recommendation, based primarily on this model, but also on evidence from other models that showed the kinds of trajectories that you see in the gray here, or the gray, where if social distancing and stay-at-home orders were to be relaxed, every single model showed that kind of growth. And so we recommended, based on the briefing, that the models, we said that the models agree that the current estimates are not sufficiently below 1 to lessen social distancing measures in the near future in the manner that could increase transmission. So looking ahead, it seems clear that the policy questions are becoming more complex and nuanced. So questions like, what if we open X, where X is construction, restaurants, schools, and what level of Y will be needed to sustain opening X, where Y might be contact tracing, testing, isolation, or wearing of masks. And you can reverse these questions because we know what our resources are likely to be, or what we would like to build up in terms of these mitigation capabilities, these containment capabilities of contact tracing, improving testing and timeliness, isolation and mask wearing. And so we can say, given those capabilities, given those expectations, how much can we open up? And another question that we are going to have to address as we move forward is, and this was highlighted in an editorial in the New York Times a few days ago, is what indicators should trigger a return of restrictions? At what point can we almost predict that we are getting to a situation that is not under control? And what is our protocol for then clamping down in a smart way? And I'll just reiterate, if I haven't hammered this point enough, is that the models can only address questions that can be translated in terms of their parameters and their defined structure. And that's why ultimately models can only be a part of the evidence that our leadership uses to make smart policy decisions. We have to have excellent surveillance and excellent data that tells us where new infections are coming from, that helps us intervene in a way that is targeted and that doesn't involve the whole state when in fact there's a local or a targeted solution. So this is my last slide, and I wanted to try to distill some of the things that I've learned that I hope might be helpful to anyone who's listening as a consumer of models, as a modeler. I think that it's hard in one slide, but these are my 5 key points. Reporters have asked me why models are so big right now and why they're useful. And I think it's that we're in an unprecedented time, and people are looking to models for some kind of predictability amidst the uncertainty, but they don't appreciate the uncertainty in model projections, particularly early on in the US, when we didn't have a lot of local experience and we were projecting based on other settings. I think that when people put too much certainty in model projections, they are inclined to misinterpret the changes. So when model projections change, people try to find an explanation for the change. The models projected high and now they're lower. Does that mean social distancing is working? Does it mean we overreacted? And that forgets that the models themselves are changing. So the change may be just due to the model itself changing as it learns from our evolving experience. And it may not have import for policies or politics. And when we forget about that, many people have an agenda, and we have to make our models agenda proof, because they can be misinterpreted or overinterpreted and used to support points that they don't actually support. My next 2 points are really for my next point is for model consumers, and the next one is for modelers. So for model consumers, I would say don't expect too much from models. Don't hang your hat on the exact numbers. Models are a guide and they're only part of the evidence. But you can expect a lot from modelers. Modelers are doing something complex. There's a lot under the hood. If they're going to bring their models to the public, and I should say not they, we as modelers have a big responsibility to make sure that we're being transparent and that we're communicating complex engines in a way that helps people understand how much they can trust them. The last thing I'll say is that I'm very happy to be in the state of Washington. I believe our leadership is working hard to do the right thing, to use the models in the right way. We have a very, very rich modeling community here, and our UW School of Public Health faculty and students are really helping, and we can be proud of that. I'll end here, and thank you.
Thanks, Ruth. I just want to encourage people to post questions. The first question that we got, not surprisingly, was whether or not you'd be willing to share your slides.
I'd be happy to share my slides. Happy to share them.
Okay, great, thank you.
I can send them. Yeah, I'll be happy to share them.
Okay, great. And then the second question was, are there models looking at the cost-benefit analysis of restrictions, such as the impact of children not being in school and the financial impact on low-income families? How are these being compared with the models of disease cases?
So that's a fantastic question, and we have to consider that. All of the models that I presented are not doing that. There are definitely groups that are looking at a more of a holistic perspective. So I'd be happy to try to source, but the person that asked that question or people that are interested, I'd be happy to try to source some good references for that.
Okay, that sounds great.
They might still be very much under construction. They may be works in progress.
Yeah, I heard from some of the Institute for Disease Modeling folks. They have a new initiative, and you're right, it's completely different project, looking at some of these issues. And I think they were expecting to have a press release with some of the initial results come out sometime this week or next week. So I would say keep your eyes peeled for that you should expect to see that. And I will also talk to them and see if we could maybe get those folks to come in and present a little bit as well. And
that question, Hillary, I could just interject. That question makes me, just really motivates the need for, we recognize that there's a tremendous toll of non-targeted policies. And we really, we talk about, we want precision intervention here. And in order to do that, though, we really need excellent data, not just on case counts, but where are the cases coming from? Are there workplaces? Are there, demographic groups? And each one of them may need a different solution. So the way to address sort of blanket pain and, quality of life impact is to really be targeted, and that's why surveillance becomes so important.
Yeah. The other thing I would say from a policy perspective is what I'm hearing more of is discussions about, as we reopen, looking at the economic impact of different sectors and how that relates to their risk of reopening, right? So trying to target sectors where they're really important economically, but maybe have lower risk, but to really prioritize opening those sectors first. And so that's another way that, you know, it's not, again, it's not something we usually think about in public health, but from a political and governance perspective is definitely something I'm hearing more about. I heard, so I'll just let Shoshana know, because I have no idea how to fix this, and hopefully she does, that someone had mentioned that they couldn't see the questions, which I remember we had that problem once before. There's some way to change the settings so that they can like promote each other's questions. So just, if you know how to fix that and you can fix it, okay. Next question is, can you or do you incorporate age and county change over time in the Washington state models?
So there currently is not a model for the whole state. So we are working, the Institute for Disease Modeling really focused initially on King County. And so we're, you know, work is underway to expand that and to do what we might, I think is called a meta population model, where you kind of put these different areas together. And the question was age and county over time.
Yeah.
And some counties are small, so we're not going to start at an individual county level, but more grouping regions of Washington. And then that's in process, yes. You know, because age contacts, you know, age groups have different contact rates with each other and across age groups, and that has to be accounted for.
Okay, next question is, this person gives the caveat, this may be kind of a basic question, which I often find are the best questions, but this may be kind of a basic question, but I have a hard time understanding why, when we open things up again, we won't just be exactly where we started. Oops, again, I feel like we are turning off the faucet and then just turning it back on, albeit in a controlled fashion. We still don't have a vaccine or herd immunity. So how is it safe to open it all? Is it simply that it is economically and psychologically untenable to keep things closed until there's a vaccine? I'll let you take a stab at that, and then I'm happy to also take a stab at it as well.
I feel like you're going to do a better job than me. So I'm going to kick the can of the big part of the question to you. So yes, absolutely. Every model projects that if we open up to where we were before, we're going to get exactly to where we were before, and faster, because you know, we started off, you know, with a couple of cases and look what happened, right? So we're not going to open up the way, we're not going to get back to what we were before. I think we have to recognize that the opening, I hate to use the word reopening because it's really a new way. So we're not going back to where we were. And so until there's a vaccine, I have some comfort knowing that it's not going to be just opening the faucet. I think we're all very aware. I think that we have to have used the time of being closed, and I think I hope we have, to get ready for opening, to be more prepared than we were. To the extent that we are more prepared and that we're prepared enough, we hopefully can keep a lid on that R and not let it go above 1. But I think it requires a multidisciplinary approach that also involves, you know, critical messaging to the public that they understand that an epidemic that without a vaccine is not a natural disaster like a hurricane. It doesn't blow over, and then and I think that I sometimes wonder if people really understand what an epidemic is. And you can't see a virus, and if you haven't had it and you don't know anyone that has or has really suffered from it, it was known that they had it, it's hard to understand. So I think that the messaging is also important, but the short answer is we're not going back to what we were, and the faucet is not opening. The containment has to be in place and the surveillance has to be in place. I think we're not where we need to be yet, but we're working hard on it.
Yeah, I think that's
Yeah.
absolutely right. I mean, with the faucet analogy, it's like we turn the faucet completely off, and now what we're doing is turning it on a little bit and seeing whether or not the bathtub continues to drain at this enough that it doesn't, the water level doesn't rise. And so then the question becomes, what have we done in terms of that, keeping, getting the water out in that analogy? And I would say that's why we're seeing all this messaging, not just from our governor, but from governors across the nation about the importance of having testing capacity and having sufficient contact tracing and case investigation capacity, because those are our ways of making sure that we will have cases and the number of cases will increase as we start to socialize, but that we have in place those control measures that we didn't have in place when the epidemic first launched. And there's, that's part of what is happening during this period. As you said, we're spending our time, I think, quite wisely during this month. So one of the big changes that has occurred here in the state of Washington is that we now have an online system that the state has implemented that's available for doing contact tracing, that's available across the entire state. And that wasn't the case before. And so that in and of itself is just a huge momentous lift that the Department of Health has stood up. And then in addition, training, a larger number of contact tracers. And we're super excited about Northwest Center's training module that's coming out, online training module. It just is going to open up the number of people who are trained and specifically trained for doing contact tracing the way that it's done here locally in Washington, because like everything with public health, it varies from jurisdiction to jurisdiction. So there's still a lot that's being worked out in terms of who's going to do the contact tracing in each of the different areas across the state and how they're going to coordinate and with the state and with big employers like the University of Washington. But we're in a lot better place than we were even just a couple weeks ago. And I fully expect that in a couple weeks we'll be in a much better place. And then the testing is another part of that as well, which is that just being able to identify people who that they need to isolate or quarantine. That's huge as well. Thinking back to, I would say most people in Washington still probably think we need more testing capacity. But the difference between now versus what it was at the end of February is night and day difference. So we are in a better place. It doesn't mean that we can turn the faucet back on full speed, right? We still have to do it slowly, make sure that we can keep it under control, and then, slowly ratchet it up. So, okay, next question. So Jim, who's like one of our regulars and always has good questions, says, in the popular media, several politicians in DC are now saying we need to turn away from epidemiology to the economic impacts of policies, which he claims, and I would agree with, is a false dichotomy, implying that our work ignores the larger impacts to people and their well-being, health, and other adverse or positive impacts of policy changes during the evolving pandemic. It's not either or. So thanks for the question on balancing impacts to communities and on disease and other outcomes and models. Yeah, and so just a thanks again from Jim saying that he appreciates, sort of that we understand there are multiple factors to take into account, and this is just one of them. Another question from Dr. Judy, is there a way to model if testing and contact tracing will work?
Okay, well, I'm glad you asked that because, it's a little bit like when you ask about cancer screening and you say, does cancer screening work, right? Well, cancer screening doesn't work unless you follow up the positive tests, you confirm them, and you give them good treatment. So tracing and testing won't work unless we can then act on that to interrupt the chain of transmission that we detect. And I actually think that that is somewhat of a question, because I think that, you know, in dense areas and low socioeconomic populations, status populations that are living, you know, densely, it can be very hard to isolate. And in other settings, people might not want to isolate. And so if we can't, you know, complete that loop, then it's a little bit like screening people, you know, bringing women to mammography and not doing anything about their positive tests. So I do think that that bears some discussion and should be a part of policy decisions.
Yeah, I know Bets has a paper that I think is just under review right now. That's actually, she and the Northeastern team looking at sort of like, and again, you know, you make such a good point, Ruth, about like the things that go into the models are the model parameters. It's not necessarily the things that we want to change, and the connection between the thing we want to change and the model parameters is, it's hard to figure out. But saying like, if contact tracing is only X% effective in reducing this, then what happens? And it was really interesting. It actually, you know, and pardon to Bets if she's watching it, I'm slaughtering her results by, or sort of overgeneralizing them. But to me, it felt like the answer was contact tracing doesn't have to be perfect to help us contain this. Even sort of a moderate response in terms of contact tracing can do a lot in terms of reducing transmission. So that was my take home from her thing.
Right.
But
it was quite an optimistic, yeah, sorry, it was quite
yeah.
But I will just say that, you know, contact tracing, again, saying contact tracing works, it can fail in multiple ways, right? You might not find the contacts, and then you might not isolate the contacts. And, you know, those two might have different implications. And then and you can actually model that out, and then, you know, come back to the leadership and say, really, we have to focus on the isolation. You know, we'd rather kind of isolate more and find fewer than finding more and isolating fewer. And these kinds of nuances are what we need to, you know, be looking at.
Yeah, yep. Okay, we have a question from Shirley. Thanks for joining us, Shirley. She says, what appears to be missing from the list of contact tracing, testing, isolation, and masks is ability to treat those who become infected and may be more or less sick depending on personal factors. So I would say yes, Shirley. So there's like, the governor has sort of indicated 5 different categories of data that he's looking at for deciding whether or not to move, counties can move to phase 2. And one of them is that healthcare capacity one. So that definitely is one of the categories that they are looking at.
Right, but the treatment, the ability to treat, in a way, these models aren't even getting there, because at least the, you know,
oh yeah, in the model
cases,
yeah,
right? Yeah, but that's very important, right?
Yeah, agreed. Yes, it's not in the models, but it is definitely part of, this is like the model is a piece of the decision making, right? It's that the modeling is one of the ways that feeds into the decision making, but it doesn't answer all the different areas that they're looking at. Yeah. Let's see. Jim would like to know, can you talk a little bit about the role of geographic data analysis and modeling?
Thanks for the question. I think that geographic data analysis is very important as an adjunct to the models, because we need to know where the cases are coming from. And so the models can help us to understand how the case counts will go up, but, you know, and address questions that can be addressed by their parameterizations, but they're not going to be able to address it all. And so that's why I think that the geographic analysis is really important as an adjunct to models. And, we absolutely need to know where the cases are coming from. We're still looking at, 150 to 200 cases in Washington a day. And are they coming from households of infected? Are they coming from close contact workplaces? Are they coming from illicit gatherings? We need to know that as an adjunct to the models. But
Okay, here's
the geographic models that model, if we were going to model the whole state, movement between different areas, density in different areas, all of that would play a role as we expand out to modeling the state. So I'm not sure if that addresses the question.
Let's see. Here's a good one from Dave Grabowski. Is the leadership of the University of Washington studying the models and taking them into account to figure out the process of opening the university in fall quarter? And the answer is, you betcha, absolutely. And also looking at a variety of different models. So yes, the answer to that is yes. In fact, literally just earlier today, we were having this conversation both on at the Board of Deans and Chancellors, and also where we were discussing the back to school or in-person school working group for the campus. But yes, absolutely.
And are you in touch with other universities on this? I mean, this is many universities, all universities really considering this. Are you working also with other universities looking at their plans?
So certainly with other universities in the state of Washington. So in that sense, yes. And the president and provost are in pretty much constant communication with, for instance, the other past 12 schools, but not necessarily around the modeling, more talking about sort of what the different schools are doing. I don't think we're the only school that looks a lot at the modeling, but we're certainly one of the few institutions that has been so clear about that the decisions that are made about university operations are aligned with public health guidance from and also that our local elected officials at all levels, that they're within the state of Washington and here locally are aligned with public health guidance. So that I think makes things a lot easier. I sometimes forget about it, how it's not like COVID is easy for any of us, but having that certainty of being able to say, yeah, our decisions are aligned with public health guidance makes things a lot easier. Sometimes I talk to reporters and they'll say like, well, what should people be doing now? And my response is always, check and see what your local public health guidance is. And we are just particularly blessed to have really good leadership and both in public health practice here in the state and locally, and also elected officials who work with them and listen to them and talk with them. So, and then you guys to collaborate with them and make sure that they have good data and evidence and modeling. Trying to see if we have any other questions before we let you go. Looks like more just sort of general things. So I think we might stop there and thank you, because that's a good note to end on anyway. Thank you so much, Ruth. That was so great. And I'm so glad that you're going to share your slides with us, because I know I'm going to want to go back and look at them again and sort of reinforce the important lessons that you provided today. It was really, really helpful. And we really appreciate having you here with us. And for people who, so thank you so much. And for other folks, if you want to stay on the line, so I know some people, an hour is enough for you, and you may choose to leave, and we will not be insulted. But we do have updates from each of the associate deans, and I'm happy to answer questions about sort of what's going on in the school if people have questions about that as well. So with that, I'm going to turn it over to, I believe, can I call on Stephanie? Are you ready for it, Stephanie? you have any updates?
Hi.
Stephanie Farquhar,
Yes, I'm here.
Acting Associate Dean for Education. Oh, there she is.
It wasn't until you said that I knew who you were talking to. Yes, no, that was a great conversation. Thank you for organizing. So just 3 updates. One is recall from last week's webinar and our email notices. We talked about the satisfactory and non-satisfactory grading option, and we had mentioned that there was a concern that a grade of S, satisfactory, may not count towards degree requirements for a student's major or towards graduation, but Faculty Senate just passed a resolution that will allow S grades earned in spring quarter 2020 to count towards graduation and degree requirements. So that is the latest update and good news for some. My second update is an announcement about the School of Public Health Undergraduate Research Symposium that's happening tomorrow from 4 to 6 p.m. Schools from across the undergraduate majors and minors will talk about and demonstrate how they've applied skills learned in the classroom to address public health problems through research and through their internship and their capstone experiences. This will include students from the environmental health major, food systems, nutrition and health, the health informatics and health information management major, public health global health major, global health minor, and the nutrition minor. So I will be tuning in. It's from 4 to 6 p.m. tomorrow, May 21st. And the link, if somebody could drop it in, is the sph.washington.edu/students/symposium. So if you could put that into the chat box, that would be great, or I can do it when I'm finished. And I also wanted people to direct people to a new article that just came out in the SPH Newscatcher called Adapting to Online Classes During the COVID-19 Pandemic. Actually, I'll put that in. But that's a great article that interviews students and faculty about teaching and learning online this quarter. And then finally, I asked some of our IT and online instructional leads from each department about what they were seeing to get an update from their perspective, since they are quite literally on the front lines helping to train us and keep our classes running smoothly. And they answered pretty consistently that they saw that there was a student and faculty sort of anxiety peak about midway in the quarter, and various departments have held focus groups. And then there was the mid-quarter survey that most instructors took advantage of. And there was a sense that faculty and students were surprised by the workload shift, or surprised by what was required with this change to online format. And students asked in the surveys and focus groups for more accommodation and flexibility with workload and deadlines, and faculty were largely open to this request. And so from that midpoint of the term where we saw this peak in sort of distress, the students have generally been signaling less anxiety about finishing up the quarter, and faculty have signaled that they're spending less time learning, sort of relearning the technology and also the prep required for each session, and they're becoming more comfortable with the learning technologies. So the departments are planning across the School of Public Health to have more opportunities to share experiences from this term, especially in an effort to bridge knowledge from what we learned this term to our summer and fall courses. So I'll drop that link to the article into our chat box for everyone. Happy to answer any questions if they come up as well.
So, okay, good, it worked. We got a message from Joe, and Joe was apparently the chat. Not everyone can put stuff in the chat, but again, I'm making a shout out to. Might just be panelists. So, Jashawn, I don't know if you can fix that or not, but Joe
right now.
Yeah. So, Stephanie, just sort of going off script here. So at Board of Deans and Chancellors today, we heard a report out from the Back to In-Person School or Back to School Working Group, and heard that they're going through this process of asking each of the schools to compile lists of which courses can't be taught online and which courses probably should be taught online, given different criteria that they provide for the fall, and then which courses we'd love to teach in person if we could teach in person, but could conceivably be taught online. And I just wanted to sort of make people aware that if they haven't heard from you already, which I think they probably have, that you'll be reaching out to them to gather that information, and that the data gathering is an important part of them figuring out what's possible for us to do for the fall. So I know people are eager to hear what's going to happen for the fall, but this is part of their developing sort of a realistic sense of what's the demand for rooms. And then they're going to combine that with the sort of like, what can we do at different phases to come up with an announcement of what's going to happen. I don't know if you want to add anything to that.
No, that's great. I know our classroom services staff were really anxious to get started on starting to look at the layout of the rooms and which courses were small enough that we could spread students out if we needed to, and how to accommodate as many courses that desired in-person instruction as possible. And so my question back to you is, was that just for autumn term, or is that for the academic year that they're seeking information?
Right now, my understanding is they're just asking about autumn.
Okay.
For fall quarter. I'm sure they'll do it for the other quarters after that, but they're just trying to figure out for fall right now. And again, for just in case I wasn't clear, because Stephanie and I talk about this all the time, and I realize like it may not be clear to everyone else. So there's the constraints both in terms of the phases of how large of a group we're allowed to have gathered, which varies depending upon which phase you're at. And then there's also even if you're allowed to have a larger group together, that they still need to be socially distanced. And so that means that what normally would be a small class, they actually require a much larger classroom. And so they're going through this exercise to try and figure out how many of those smaller classes that would be allowed to meet at different phases could we actually accommodate, given that we have a smaller inventory of the larger classes. So that's why they're asking for each of the schools to come back with this list of has to be in person, which means it would be canceled if we're not at the right phase, versus, yeah, all signs point to it should be online, versus we'd love to do it in person, but we could do it online if we have to. So that's sort of, I'd say, the three bins.
Yeah, and that I appreciate you mentioning this, because I will be contacting each autumn instructor to get that information. I'll also be asking if we are able to accommodate and teach in person, are you comfortable with that? I've had a few emails from faculty who are not fully sure, which modality they prefer, given their own situations. So. Yeah. Great. Thank you.
Okay. Okay. Great. Lisa, do you have updates for us? Lisa Manhart?
I do.
Associate Dean for Research. Okay.
Just a couple of them. We are still in phase 1 of the state's reopening plans. And as we talked about last week, there have been some additional in-person research allowed, but that does require that the PIs put together return to in-person research plans to do this safely. DEOHS has already completed this. They've released their plan for laboratories in the Roosevelt building. And it's really a nice blueprint for others who are preparing to put together these plans. And just to remind you about what has to be included in these plans, there has to be some kind of training prior to returning to campus so everyone understands the plan. Of course, measures to keep density of people low, so physical distancing can be observed. Wearing of masks or face coverings, daily symptom attestations in workday, and then the overall designation of a COVID-19 supervisor for each of the individual units to kind of keep an eye on how well things are going, being able to adhere to these requirements. In anticipation of some of the optimistic comments that Hillary made at the beginning about what phase 2 might look like as we continue to gradually reopen things in Washington State. The Human Subjects Division is hard at work developing new guidance on additional in-person human subjects research that will become permissible actually potentially very soon. They've been working hard on this and anticipate being able to release some new guidance on what additional activities might be permitted in the next week or so. And then finally, the Population Health Initiative just on Monday, I believe, announced another funding opportunity. These are the COVID-19 Economic Recovery Research Grants. They're very similar in format to the recently funded Rapid Response Grants. So they'll fund up to $20,000 per project for short-term projects of about 5 months. And although the emphasis in this call for proposals is on economic recovery, there actually are several topical priorities within these that fit, I think, quite well with the School of Public Health research expertise. 3 of those include equity and inclusion, health disparities. Another is emphasis on limiting risks at work sites. They'd like to see proposals addressing that. And then the third area that's very related to what we do here at the School of Public Health is a desire for proposals looking at relationships between individual and group risk perception and then the behaviors that people engage in, both physical distancing as well as desires to return to restaurants and shopping and other things that will open up as we gradually open the economy. As we did for the rapid response grants, the School of Public Health will provide matching in the amount of $15,000 for projects with a School of Public Health faculty member as PI, and $5,000 for proposals with an SPH faculty member as a co-investigator. The timeline, as usual, is very short. The applications are due to the Population Health Initiative on May 31st. So please contact me by May 29th if you want to request School of Public Health matching funds. And that is it for me. Happy to answer questions when we get to that point in the rest of the webinar.
Okay, thanks, Lisa. Actually, you know, so Lisa, your comments about the sort of return to research in person reminded me to provide some clarifications. So just so that people could put it in a larger context, our research here in the School of Public Health meets the state's criteria for essential work. And so we are allowed to be doing that research under phase 1. And so, but the governor requires that each unit, which in this case is the individual PIs, have these plans in place. So when you're seeing them talk, when you see units like the OHS talk about return to work, it's this research component of it in person. But as we enter phase 2, there will be more opportunities for people who are not don't have critical must be in person to start returning to work in place. But like you're seeing with the research plans, the governor will require units, which for that part of it will be at a minimum at the school level, it could be at the department level, to have plans for how they're, who's going to be the designated person to check and make sure that people are doing their attestations, who's the designated person to make sure that there's trainings in place, those kind of things. And so what's going on behind the scenes on the campus level right now is just like we have a return to school group, we have a return to work group that is busy developing templates and checklists that different units can use to develop those plans, and also developing trainings for and guidance in terms of what the expectations are. So for those of you who are sort of thinking like, what's it going to look like when we come back to work? There's going to be a lot of guidance that'll be coming out both in terms of how to plan for that and then how, what needs to be in place in order for people who are not research, but who are more on the admin side of things to start returning to work in person. And I just wanted to reiterate, because every time we talk about this, I hear angst from people, that under phase 2 and phase 3 of the governor's plan, individuals who are at high risk for developing severe symptoms for COVID are still encouraged to abide by stay home, stay healthy. And we as an employer will be providing accommodations for those groups. And so if you have concerns about that, for sure, talk to your supervisor, your HR manager, if you need accommodations to be made. So just want to make sure that people know it's like, we're not, just because we're going to start allowing more people to come to work doesn't mean, one, that it's just going to be one day everyone's back. It'll be phased in, like slowly turning on the tap again. And also that for phases 2 and 3, there's still pretty significant emphasis on encouraging people to work from telecommute if they can, so that we can keep the numbers on campus down. Janet, before we sign off, do you have any updates about practice stuff that you want to add?
Hello. I'm a little bit of a disadvantage because I didn't get to hear your intro, so I don't know what you already covered. So maybe what I'll just, maybe I'll talk about contact tracing for a moment, because it's such a big topic, and it's also why I was late. So I was on a call just a little bit ago with folks at the Department of Health and Public Health Seattle-King County and our own Environmental Health and Safety Office about how we're going to be coordinating case and contact investigation work, as a large employer, as the public health agencies. It was really, really interesting. So that is in the works. And then, did you give an update on the apps stuff, Hillary?
No.
Okay. So, if you haven't heard, the University of Washington Computer Science Department has created an app to do contact identification. And if you've heard about this Apple, Google contact tracing thing, it's related to that. And Washington State is kind of interested in looking into it and seeing whether it works and whether it can be done in a, kind of equitable way that respects everybody's privacy and security. So those have been some really interesting discussions, because it would be a completely novel way to be integrating with traditional contact tracing practices. So that is interesting. And then I saw a little notification here in the Q&A that the Northwest Center's Every Contact Counts training module was just released. So that's also exciting.
Okay, we have a few minutes left to deal with any general questions. I hear a comment from an anonymous attendee saying, it seems there has been a silver lining to all this in the flexibility that comes with remote work, and asking whether there'll be more encouragement or support for remote work post-COVID. I think that depends upon what the work, what type of work it is, right? So what we're seeing is, like, there are some sectors where they're realizing, hey, it works just as well for us to be, we're seeing this from, trying to remember, Box, one of, some of the tech companies, particularly online ones, are like, hey, this is working great for us. We may just continue this way. I think, there's some things that we may feel that way about going forward. I certainly feel like we found the utility of using Zoom for connecting with people in ways that we hadn't been using it previously, and getting participation across the school in conversations that would have not included as many people perhaps in the past. So to me, that's a really strong one. I personally miss physically coming to work and interacting with people. I still, I miss just being able to have the casual conversations and on the spot problem solving. So for the kind of work I do, I'm not so sure that like it's a great long-term solution. But I'm sure there are some areas where people are like, yeah, it's working awesome for me. So I think it's going to vary from area to area. Let's see, question or comment, maybe it is. If this quarter, this is an anonymous attendee, if this quarter is any indication of the upcoming workload for transitioning more of my classes to online, I am worried about being able to meet that same workload while homeschooling the kids. There are accommodations for this quarter, but will this be the case moving forward? My guess is that expectations will be different. So I'm not sure whether this is coming from a faculty member or from a student, and then now that I say that, I'm not sure that it matters. But yes, you are aware, you are right in terms of that we have really strongly been messaging to supervisors, to instructors, to all folks of this isn't normal, and there's a lot of external factors that are contributing to people not being able to get their work done in the volumes or timeframes that perhaps they're used to, and so to be kind and compassionate with each other and yourselves. I genuinely hope that we are able to continue that messaging in the fall. Ruth made a comment about that this is not like a natural disaster where it comes through and it devastates and it's gone. I think, you know, this is part of what all of us are struggling with, both in terms of work and just psychologically, is that this is just such a long haul that we are all in for. But yes, we will try to continue to be compassionate and to make sure that we are both in formal and informal ways, recognizing the strain this is putting on people. And please do continue messaging to us. You know, that really became clear for me this week. You know, just occasionally people send me messages. I got a message from a student that was really heartbreaking, just of like all the different things that individual was juggling. Some of which are related to school and some of which are not related to school, but, you know, we're complete human beings, and all of those things intersect in terms of our lives. So I appreciate getting those messages. I think it also helps us who are in leadership positions to remind us of what people are going through and that there are areas that we still need to continue to work on. Another one, it started to say this, Lisa was gathering information for our legislative liaisons about how COVID is impacting people's ability to make progress on their research and how that's impacting their, you know, how possible it will be for them to continue the research projects. And again, it was just heartbreaking reading the stories. I know how much each of you love the work you're doing and how passionate you are about it, and you're doing amazing work. And it's frustrating not to be making progress. And it's also frustrating to think that the steps that we're taking right now to try and be compassionate with the members of our community are going to have long-term impacts in terms of the viability of those projects. So I just want you guys to hear from me that we are hearing you, and we are trying to make sure that those messages go up the food chain, both institutionally, but also to folks in DC who could hopefully provide some additional financial relief in terms of research funding. But yes, we will continue to be compassionate, and please continue to share your stories with us, if only so that we can be aware of what you're going through and try to mitigate in whatever way that we can. So not a very positive note on which to end the webinar, but I noticed we have no open questions. So I guess our thoughts are with all of you guys, and we're coming up on a long weekend. There's some positive news. I've gotten a lot of questions from reporters of what you can do this weekend to get together with people that you love in a healthy way. So I have some stock answers to that. Answer number one is, of course, getting outdoors and doing something outdoors where you can maintain that physical distancing. My husband reminded me that Memorial Day weekend is traditionally a barbecuing with friends and family weekend. And so, if you can have a barbecue where you're still 6 feet apart from each other so that you're physically distanced, maybe do that with a very small number of friends. It's a good way to go, or maybe choose to go for a hike with them instead and keep apart. But yeah, we're all struggling with it. Ruth, did you want to say a couple of last words? We really appreciate you being on. I just noticed that you popped back on all of a sudden. So thank you so much for joining us. It was really great.
It was a great pleasure, and I'm not, everyone can find me if anyone has, questions or thoughts. This is a big work in progress, and we're very delighted to be a part of it. And I want to just, again, shout out to our students in the Department of Biostatistics who are working with us, Jean Feng and Serge Leschengundel, and the faculty members, Barbara Richardson and Noah Simon. And thanks again, Janet, for creating that opportunity. And it's really an honor to be involved. Thank you.
Thank you. Stay well, stay healthy, everybody. See you next week.